All right, let's dive right into these core clinical principles of vascular and pulmonary embolism management. We're kicking off our continuous high-yield review. Question 39. We've got a 58-year-old male with an oral cavity carcinoma, and we need to accurately map his cervical lymphatic basin. The challenge here? We need the absolute most specific non-invasive technique to tell a benign reactive node apart from a real-deal metastatic node. The correct answer is option C, SPIO-MR lymphography. Notice how this technique creates a distinct signal void in benign tissue. It's actually pretty cool. Normal, functional reticuloendothelial cells just gobble up these targeted iron nanoparticles. But metastatic cells, they can't do that. That makes this scan way more specific than your standard imaging. As a quick exam pearl, keep in mind that while 18F FDG PET scans are highly sensitive, they completely lack the specific ability to distinguish highly active benign inflammatory nodes from actual tumor nodules. Question 40 features a 56-year-old female with severe chronic venous insufficiency, presenting with a constricted, fibrotic lower calf that tapers sharply right above the ankle. This pathognomonic inverted champagne bottle leg deformity is caused by option B, advanced lipodermatosclerosis. This brilliantly illustrates the CAAP stage C4B progression. Basically, persistent chronic venous hypertension drives fluid right into the interstitial matrix, causing severe subcutaneous fat necrosis and dermatosclerosis, giving you that exact appearance. A key exam pearl here is understanding the mechanism of hemosiderin deposition. Macrophages degrade those escaped red blood cells, release iron, and that's what drives that characteristic permanent brownish skin discoloration. Question 41. A 33-year-old male develops a high-output arteriovenous fistula in his thigh after a trauma. When the surgeon applies firm manual compression proximal to that AV fistula, what physiologic response confirms a positive Nicoledoni-Branham sign? The answer is B, the disappearance of the local thrill paired with a reflex bradycardia. So here's the physiology behind it. Abrupt occlusion of this low-resistance shunt suddenly spikes your systemic vascular resistance and arterial blood pressure. That sudden spike hits your baroreceptors, triggering a massive vagal parasympathetic discharge, and boom, reflex bradycardia. You absolutely need to know this sign because unresectioned large AV fistulas can eventually accelerate venous return and push the patient right into high-output cardiac failure.
Question 42. It's post-op day 5 for a 42-year-old female, and she suddenly gets chest tightness and severe shortness of breath. What's the most statistically common presenting symptom of an acute pulmonary embolism? The answer is C, respiratory distress or dyspnea, which shows up in up to 92% of documented cases. The crucial clinical distinction to make here is between dyspnea, which is the leading subjective symptom the patient complains about, versus tachypnea, breathing over 20 times a minute, which is the leading objective sign you'll actually document as the examiner. Oh, and side note, the classic ECG footprint is simply sinus tachycardia. That famous S1Q3T3 pattern, you're actually seeing that in less than 20% of cases.
Question 43. A 35-year-old female stuck on strict bed rest for 7 days after a femur fracture, who also takes oral contraceptives, suddenly develops severe left calf pain and deep tenderness. The most likely diagnosis here is A, deep venous thrombosis. This case is basically a textbook illustration of Virchow's triad. You've got endothelial injury from her initial orthopedic trauma, profound venous stasis from the strict immobilization, and a hypercoagulable state driven by the exogenous estrogen in the OCPs. It's the perfect storm for a DVT. These types of major lower limb orthopedic fractures carry an exceptionally high risk for DVT and secondary pulmonary embolism. Question 44. Which clinical profile is the least likely predisposing risk vector for developing a DVT? The correct answer is C, a fully ambulatory mobile outpatient. It's absolutely crucial to emphasize how the active mechanical compression from the calf skeletal muscle pump acts as your body's natural physiological defense against dangerous venous stasis. It literally pumps blood superiorly, fighting gravity. Just contrast that with the pearls listed. Congestive heart failure slows down your venous return, malignancy triggers systemic hypercoagulability, and obesity physically obstructs venous outflow. All of those drastically increase your DVT risk. Question 45. You've got a 28-year-old trauma patient on a continuous unfractionated heparin infusion for a DVT, and he suddenly develops severe, life-threatening hematemesis. Immediate next step. Option B is the correct course. Stop the heparin infusion, administer intravenous protamine sulfate, and place an IVC filter. In a catastrophic hemorrhagic complication like this, you have to immediately halt the heparin, safely reverse it with its specific neutralizing antidote, protamine, and then mechanically protect the pulmonary tree with an IVC filter since systemic anticoagulation is totally off the table now. Burn this exact dosing pearl into your memory. 1 milligram of protamine sulfate neutralizes approximately 100 units of circulating unfractionated heparin. Question 46 asks for the most alarming clinical prognostic indicator of an adverse outcome in a documented acute pulmonary embolism. The answer is C, altered mental status and confusion. Listen, altered mental status here isn't just simple brain fog, it's a massive red flag indicating a severe drop in left ventricular output and global cerebral hypoperfusion. A massive PE blocks blood flow to the left atrium, completely crashing your cardiac output. The primary core prognostic triad for a high-risk PE includes this exact hemodynamic instability, along with active malignancy and evidence of severe right ventricular dysfunction. Question 47. A 45-year-old post-op female has new onset tachycardia and hypoxia, making us highly suspicious of an acute PE. The most appropriate first-line non-invasive imaging to confirm this is A, computed tomography pulmonary angiography, or CTPA. While CTPA is unequivocally our gold standard diagnostic tool, giving us amazing sensitivity for spotting filling defects, you absolutely have to remember those critical absolute indications for pivoting to a VQ scintigraphy scan instead. You must use a VQ scan if the patient has severe renal insufficiency, a documented anaphylactic contrast allergy, or is pregnant, just so you can minimize radiation to the fetal thyroid. Question 48, we're looking for an absolute indication for inserting an inferior vena cava filter. The correct option is C, a documented deep venous thrombosis in a patient with a contraindication or major complication from anticoagulation. We need to keep a really strict clinical boundary here. IVC filters are reserved exclusively for proven venous thromboembolism, where standard systemic anticoagulation is absolutely contraindicated, has already resulted in a life-threatening hemorrhage, or if the patient experiences recurrent VTEs despite adequate therapeutic levels. Things like free-floating clots or high-risk trauma prophylaxis without an actual clot, those are not supported as first-line absolute indications. Question 49. A patient develops a confirmed segmental pulmonary embolism, but remains alert and hemodynamically stable. What is the most appropriate next step? The correct action is A. Initiate systemic anticoagulation with an intravenous unfractionated heparin infusion or subcutaneous LMWH. You need to stabilize that clot matrix. This brilliantly illustrates why we literally never start with oral warfarin monotherapy. You absolutely must bridge with heparin, because warfarin initially depletes your short-lived natural anticoagulants, protein C and S. Doing this without a heparin bridge induces a dangerously procoagulant state that can literally cause skin necrosis. Question 50. What's the most commonly performed non-invasive bedside test to confirm an infrainguinal DVT? The answer is C, compression duplex ultrasonography. The absolute definitive ultrasound hallmark you're hunting for here is the complete physical non-compressibility of that venous lumen right under your transducer pressure. Keep its anatomical limits in mind, too. It is highly reliable from the groin down the leg, but for a suspected isolated deep pelvic venous thrombosis, gas and body habitus get in the way, making MR venography your gold standard there. Question 51 is a quick practical calculation. An otherwise healthy 70-kilogram male needs a systemic unfractionated heparin regimen for an acute DVT. What's the standard initial IV loading bolus? It's option C, 5,000 units. Standard protocol dictates an initial bolus of 70 units per kilogram, so a 70-kilogram patient requires roughly 4,900 units, which standardizes to that precise 5,000-unit intravenous loading bolus. You'll maintain this by targeting an activated partial thromboplastin time, or APTT, of 1.5 to 2.5 times the control baseline. Question 52. A surgical resident is inserting a chest tube to manage a massive hemothorax. To minimize injury to the intercostal neurovascular bundle, how should the tube be directed? Option B, walked over the superior or upper border of the lower rib. To avoid a catastrophic intercostal hemorrhage, you always skate your instruments over the superior border of the rib, safely bypassing the vein, artery, and nerve tucked tightly beneath in the subcostal groove. And always remember the safe triangle, bounded by the latissimus dorsi, the pectoralis major, and a line tracking the fifth intercostal space. This final core laboratory monitoring reference table summarizes unfractionated heparin tracked by APTT and reversed by protamine, low molecular weight heparin, which completely bypasses routine monitoring, and warfarin tracked by PT/INR and reversed by vitamin K or PCC. Memorizing this is absolutely essential for clinical mastery, but looking at this leaves us with one fascinating question. As pharmacology constantly evolves at lightning speed, what novel targeted anticoagulants might soon render these complex monitoring parameters completely obsolete?